So our next speaker is Amy Viehoever. She comes to us from Washington University and St. Louis University. She is a movement disorder specialist, and she's going to talk to us about the GNAO1 natural history study.
Okay, so I'm very excited to be here, and very excited to see both old faces and new faces. I think the last time we talked like this in the U.S. was pre-COVID, which seems like a generation ago. So I run in coordination with Erica and the Bow Foundation. We run the first natural history study. There's currently one that you'll hear about more, also ongoing in Europe. So I'm hoping to, a few of these slides will be redundant for those of you who have heard or seen me talk before. But in this presentation, I'm hoping to bring some of the longitudinal data that we haven't yet discussed. But just to orient everyone, we first met with the Bow Foundation in November of 2017, and just to educate those of you in the audience of how these efforts organically evolve. It was a joint family and scientific conference, kind of like this, and we decided that if we were going to meet frequently, that we should start collecting data and moving towards a natural history study. So we launched this a research clinic in conjunction with the Family and Scientific Conference in April 2019. It was scheduled again in 2020. Of course, that we had to pivot, and then we switched to virtual online data collection and collected as much data as we could. There were some things that obviously we could not do virtually, and we collected that over the course of 2020 and actually expanded our numbers dramatically, including 11 families from the Spanish cohort, and other families from all over the world, which was fun. In 2021, due to funding constraints, we restricted our data collection to the 15 subjects that we already had 2 years of data on. And then in 2022, we reopened the clinic. It was somewhat of a reduced number. Again, I think it was, I forget exactly how many, 20 maybe, but was able to resume in-person data collection. So the structure of the research clinic, you could think of it as stations, although it was really kind of all together. But we would have information gathering, trying to gather all the medical records, EEGs and MRI images when possible. There was a complete neuro exam done with a movement disorder assessment in the first 3 years by me. And in the last year, Jordan Garris from UVA helped collect this data, and then I've been reanalyzing it. Erica, Dr. Axine, did the epilepsy assessment, and then we also had occupational and physical therapists, and we've had the same therapist over the course of 4 years, so they've really gotten to know the disorder and have come up with ideas of how we can better assess it. So just in summary, the data that we currently have had, so I've collected a couple more subjects just from kids who have come to my clinic for consultations. So we have 52 subjects with at least one time point of data, and 4 subjects with 2 years, 5 subjects with 3 years, and 10 subjects with 4 years of data. We've had more interest, and we, just because of bandwidth and funding, we haven't been able to collect more data, and I would love to brainstorm with people ideas of how to get around that. We have had 2 subjects pass away. One was 7, one was 8. One had epilepsy, and we think that it's a little bit unclear to me, but probably from that. One died due to combination of respiratory compromise and increased movements. It's really unclear from the descriptions, both from the parents and the chart. And although the bulk have been from the US, we have had a Spanish cohort as well as Romania, Italy, Argentina, and Switzerland. So unfortunately, I was hoping to have this chart updated. That didn't make it in time, but the trends are the same. So the clinical characteristics all had hypotonia as an infant, of varying degrees. Most families said that all families said by the age of 6 months, if they weren't noticing it, their pediatrician was noticing it. At the time of assessment, all but one had some form of motor impairment. The one subject that scored normal on all of our tests had a DBS placed some 10 years before and had been continuing to do well. 13 of the 52 have epilepsy, and I think that's a discertainment bias because kids who have epilepsy and GNAO1 typically are more sick. They have more hypotonia, they're more susceptible to infections, and so it's harder for them to travel. I think we saw an uptick in the number of kids with epilepsy when we did our virtual data collection, and so this is something that moving forward we've really put a lot of consideration to. And we define epilepsy in the standard term as having two or more unprovoked seizures separated in time and space. So, not having seizures just when sick, not having just 2 seizures in one day. Of those patients, 3 of them had historical epilepsy but had not had seizures in many, many years and were off medications. And when I went through and characterized the types of the movement disorder, the vast majority of these children had a mix of dystonia and chorea. There's a few that I could only detect dystonia. Some of those had DBS. And then at the initial assessment, 4 only had hypotonia, although as some of those children have grown and developed skills, some of the dystonia and the chorea has emerged. Okay. And so I have been using the GMFCS score, which is Gross Motor Function Classification Scale. It's a scale that was developed for cerebral palsy, and let's just be clear, whether or not cerebral palsy is defined as a non-progressive motor disorder. So whether, it's a matter of semantics. A lot of us think that GNAO1 is somewhat separate, but oftentimes for families, I will say, cerebral palsy is what people know, right? So you just say, my child has cerebral palsy due to a genetic condition, right? And I think that helps people in the community understand what's going on. So on this scale, 1 is a kid walking around that the average person can't tell has cerebral palsy, and 5 is someone who has to rely on a wheelchair and cannot maintain sitting balance. So you can see that we actually have quite a spread throughout our cohort. Certainly majority, are 4s and 5s, meaning that they're in the wheelchair most of the time, but a substantial number of subjects that are higher functioning from a motor perspective. And as I pointed out at the last time, and that has been replicated by our colleagues in Spain, the level of the motor disability does not necessarily correlate with the abnormal movements. And what we really found is that it's really, the hypotonia is really what drives the overall motor impairment. But it's the abnormal movements that land the kids in the hospital. So it's a little bit of a dichotomy. So both are important, but don't necessarily always correlate with each other. Okay, so looking at how these movements change over time, because that's been one of the biggest questions of and why we want to do a prospective study which is painstaking, right? Every year collecting more data, right? We want to know how this changes over time because there's been, especially early on, there's been suggestion that this was a neurodegenerative condition or something that got worse over time. Looking at the data, it's really not clear. I would say that going into this study, I really expected to see more significant clear neurodegeneration getting worse over time. And we really did not see that consistently. The vast majority, and we'll get to this in a few other metrics, the vast majority of the kids didn't significantly change year to year. So the first, is there a pointer here? Or maybe I can use my ear. So I didn't go through the scales for you for sake of time. The gross motor function measure is just a measure of gross motor function. Sitting, walking, reaching, and it's a very detailed assessment done by trained physical therapists, and I think is a somewhat good measure for GNAO1 because it's one of the few things that does capture the breadth of motor function. So even if a child can only turn their head one direction, that scores a point, as opposed to some of these other measures like the Burke-Van Marsden, like the abnormal involuntary movement scales, which have what I consider floor and ceiling effects, which means that a lot of our kids might score the very worst on these scales, and even if they improve, their score does not change. So that's very problematic, right? And it's a huge problem in pediatric movement disorders in general, because a lot of these scales were developed for adults and then have been retroactively applied to children, but we use them because they're considered the gold standard and is what everybody expects. So the GMFM is a score of 88 measures. So on average, when I took year 3, and I should back up and say, this data I analyzed after talking with a statistician. I lumped together patients or subjects that had either 3 or 4 years of data, and I took the first 3 years. There was one subject that we had to exclude because on multiple attempts, we tried to examine her and she was asleep. But you can see the mean change was 1 point, which is not particularly clinically significant, right? There was some variation there, and some kids did actually improve and some got worse. The Burke-Van Marsden is the gold standard historically for evaluating dystonia. A mean change of 3.1, I saw, but you can see there's a huge variability. And because of this variability, I didn't really think that while a change of 3.1 could be clinically significant, I can't really say that has any meaning. The only thing that maybe might worsen over time is the involuntary movement score. And this was a surrogate for chorea, so the wiggly kind of movements. There was a trend towards being worse over time, but again, you see the standard deviation, so it varied widely and was not consistent. So now we're going to look at the Clinical Global Scale of Improvement. So this is called the CGI. This is the crudest of all crude measures, right? So it is literally a scale of no disease, mild disease, marked disease, or is it mild, moderate, marked, severe, most severe, right? And it is simply the clinician's global impression and is the score that I make after I spend an hour with the child, talking with the family, how's the past year gone, looking at them, examining them, and say, I think they're a little bit better, I think they're a little bit worse. But it is used a lot in clinical trials, especially in situations where there's not a great endpoint, right? So as you can see, like in the motor function, there was quite a broad range of from very mild disease to the most severe disease that we've encountered. The majority of children and young adults fell into the moderate to severe category, so right kind of in the middle. And when I looked at these patients with 3 to 4 years of data, 2 improved, 10 remained the same, and 2 worsened. So kind of going on the theme of there's not a significant trend towards neurodegeneration, at least overall in the population that we studied. Now, what we studied is a sample of all patients with GNAO1, and I already told you that I think there's some bias, right? I think there's both bias and we may not be seeing the sickest of the sick patients, and we also might not be seeing the very mild cases where there's not a motivation to come to these to participate and to come, travel and have all this assessment if, hey, I'm doing fine, right? So, in looking at these metrics, we knew going into the study that a lot of these metrics were going to be imperfect, right? But we felt like we had to look at what is the standard, right? And then evolve from there. So what we really found with the AIMS, which looked at Korea, is that we think that there was tremendous inaccuracy due to the variability of the symptoms, and all the parents know this. Like, the movements vary from moment to moment, time to, hour to hour, day to day, right? And so what you're really capturing is a snapshot, and actually I felt like my scoring got more accurate with the virtual assessments, because then I was spending like an hour, watching the physical therapy assessment, and so I was able to evaluate the abnormal movements in multiple different, in the home setting, but in multiple different, at rest and with action, et cetera, et cetera. The Burke-Van-Marsden has really bad ceiling effects. The GMFM, it's good because it has no floor or ceiling effects, but it's very time intensive. It can take up to an hour to complete, and it has to have a trained physical therapist, so not terribly practical for especially a bigger clinical trial. The modified Ashworth, which it's a very crude measure of spasticity. It's a good answer. Does the kid have spasticity or not? And that's really all it answers. And it cannot be done virtually. The Peabody, which is a kind of well-used, well-validated measure of development that's used, both in assessing normal children and, children with disorders. We really did not feel like it was a good measure at all, and we scrapped it after the first year, in part because it was very rigid. It's very rigid in how you assess children, which is good in keeping things consistent, but it did not account for adaptations that children had developed, which we think is important, right? Because we want to look at function and abilities and have a way to track that. And so didn't have time to include these slides, but our OT, Karen Balk, has worked on coming up with an adapted version of this, and we may be contacting some of you families to bring this to your therapy sessions and see if we can validate this fine motor assessment. And then we use the CP Child as a measure of quality of life. However, when you really look at the scale, it really is mostly about caregiver burden. And okay, sometimes caregiver burden doesn't improve. So in trying to improve that, we have been looking at more quantitative measures that we can do in the home environment. So this work was piloted by a master's student in engineering, Evie, who's been recruited away by Medtronic. We went into this with hoping to, with the notion of trying to quantitate the abnormal movements. And our hypothesis was that the kids with GNAO weren't going to move less, but that their movements were going to be more jerky, and there were going to be qualities that we could pull out. And so right here, you'll see right versus left, age-matched control versus a child with GNAO1. You can see that the movements, while the magnitude of the movements in GNAO1 can be higher, the overall movement is more in the control subject, and it's grouped together. So you can see, you can really define, the kid was playing on the playground here, and then was sitting in class, and then was playing again here, walking, going to the bathroom, right? And you really don't see that in the child with GNAO1. And so then when we look at some more, to me, interesting markers, so I'm gonna just briefly look at this. So what we found is that total movement time was less, but the magnitude or the acceleration, which I expected to be higher in GNAO1, was actually much less. And this was true in all the kids that we did. However, the jerk, which is the third derivative of movement over time, or the derivative of magnitude, is way higher in GNAO1, meaning that the change in acceleration is higher, and the variance of the frequency of the movement is much, much higher, meaning that the movements are less coordinated and less smooth. And then what we did is, as a kind of negative control, we said, well, is there any difference between left and right? Which we didn't expect any difference. And sure enough, we didn't find any difference, and it's the same as typically developing children. So I just wanted to take 1 minute to address this question that I had a lot from people about DBS. So there's this dichotomy of, experiences in GNAO with DBS. Some people have said that it's a lifesaver, and other people have not had good experience, and there have been children who have died after having DBS, okay? So let's be clear, the dystonia rating scales often do not significantly improve, okay? The problem is, I think I've shown you that the existing rating scales aren't great, in that the rating scales really don't capture, meaningful what's going on at home. And that it's really the chorea and these dynamic movements that respond better to DBS than your fixed dystonia postures. So I think that's one reason that rating scales don't change. And then some children have had progression of spasticity and fixed dystonia after DBS, even though their chorea and hyperkinetic movements are controlled. My counterpoint is that I firmly believe that many of these children would not still be alive. So even though they've had progression of their spasticity and fixed dystonia, they're still alive. They're still enjoying life. And that's something to be said for that. And when their DBS fails, oftentimes they end up in the ICU. And this is what I'm talking about. So this is one of the subjects in our study.
Oh, it's streaming now, okay.
So we're collecting data for another DBS study, trying to understand the local field potentials in relationship to the movement. So here we just turned it off, okay, to record, and you can see her dystonia and chorea is getting worse. She's getting more and more uncomfortable. You can clearly see she's not happy, right? And this actually progresses to the point that we had to stop the recordings because she almost fell off the table, and she was just clearly in so much discomfort that I couldn't, I couldn't go on with it. And so, as you'll see here soon, we turn it back on, and this is what she looks like. So within 10 seconds of turning it back on. So clearly, even though she has had progression of her spasticity and dystonia, the DBS is still working, and when her battery failed, she ended up in the ICU. So that is the nuance that I want people to take away from it, and I also want people to realize that there needs to be balanced expectations. This is not going to work as well as it works in other genetic dystonias. There can be progression of symptoms. That doesn't mean it doesn't work. Yeah, okay. So, well, we're going to end there. I think I've made all my conclusions.